Hello, I'm Peter Knapp. This is my presentation on what impact does digital multimedia information have on recruitment trials in children and young people, and we're reporting the TRECA study. So the justification for TRECA is that there's a lack of trial evidence in children and young people in particular. So just as a way of illustrating that, in the last 30 years, the publication rate in adult trials has gone up about 100%, the annual number of trials published. But in children and young people, it's gone up just 20% in that period. So not only there are fewer trials in children and young people, but actually the rate of increase is much less than in adults. And one of the justifications for TRECA is that current information is really not that great. So information plays a crucial role on people's decision to participate in research, particularly clinical trials. And the information, as you know, has been mandated by the Research Ethics Service and has to be approved by research ethics committees. And mostly the information we give is printed, and that's been criticised for a long time for being often too long and technical, not very engaging, hard for people to navigate. And it's thought that that particularly affects people with lesser literacy skills. And so a few years ago, the UK Health Research Authority encouraged people to look at developing non-print media. So we did a study looking at multimedia, and the justification is that you can present information in a number of formats, so you increase choice. The multi-choice format effectively allows people to personalize the information, and digital information provision and its access is commonplace, but not universal, but commonplace in the United Kingdom. So the TRECA study had two phases. One was a development phase, a long development phase over 12 months, which was about co-design or participatory design. And then in phase two, we did 6 SWATs, that is 6 studies within a trial, in which when people were being recruited to clinical trials, they were randomized to receive either digital information or printed information or a combination of those things. So quickly go through, we did a qualitative study initially in phase one, interviews and focus groups with children and young people, parents, clinicians, and trial staff to try and inform the development of the multimedia. We then developed a prototype based on a thing called the Skippy trial, and we user tested it amongst small groups of people. User testing tests people to ability to find information and then answer it correctly, and we made some changes to the prototypes based on the results of the user testing. We also did quite significant amounts of patient and parent involvement throughout the study. So extensive work, multiple meetings with PPI group. They provided email feedback on draft multimedia, on the animation scripts, and so on. And we also did readability work on the text. So we had a readability expert on the team who used his expertise and readability indices to revise the text to enhance understanding and to make it age appropriate. And then the multimedia we produced for each study, we produced a younger version that's intended for children aged between 6 and 11, and then an older version, which is either for older children or their parents. So parents viewed the version that was intended for adolescents. And it was so on the home page, here's one of the studies. It had what's called an explainer animation, a 1-minute animation, which explains the study, and then some generic animations, which were the same on all of the trials. And then it was structured in a small number of web pages with some other talking heads videos from the PI and people who'd taken part in the trial. So the phase two, we did 6 SWATs, and here's some details of the host trials that we looked at. And so 5 of them were individually randomized. 1 of them was cluster randomized. They either tested 3 groups or in the case of the forced trial, just 2 groups. And then we would do a prospective meta-analysis, combining the data from those 6 studies together in a meta-analysis to look at the effects on recruitment rate. And here's what we found. Unfortunately, there were only 3 trials where we had data from 6 SWATs, but 3 of the SWATs turned out to be very small for a variety of reasons. And so we only had data from 3 trials that we could combine in the meta-analysis. And what we found was that the intention to treat analysis on recruitment, comparing multimedia only versus printed information only, we had an increase in the recruitment rate. And the odds ratio, as you can see, there is 1.54 in the meta-analysis, with quite wide confidence intervals going from a value just above 1 to 2.28. So it was just statistically significant. So we showed that providing multimedia only increased the recruitment rate to trials. When we looked at comparing combined multimedia with printed only, we saw no difference. We looked at the effect on retention in the trials. Once people have been recruited, we looked at who stayed in the trials at up to 6 months after recruitment. When we compared multimedia versus printed, we showed it had no effect. So essentially no effect, but no loss of those additional people who've been recruited. When we compared combined multimedia and printed information with printed information only, we showed no effect on retention, very wide confidence. And then when we looked at decision-making questionnaires, people evaluating their ability to make decisions on the information, we showed no effect of the of information. So the only significant difference was on recruitment, which was greater in multimedia only compared with printed only. So the conclusions of the study are that using multimedia is feasible and it's acceptable to trials and to research ethics committees, which I think is a really significant finding. There's some evidence that multimedia increases recruitment rates. There's no impact on trial retention, but there's no loss either of those additional people who've been recruited. And there's some uncertain effect on decision making amongst participants. And so the implications are, we think this finding is important, but there's a need for replication. For example, what are the effects in adults? There's only limited evidence on multimedia in that population. What are the effects on communication with recruiters and clinicians? Does it change the way that they interact with people? What are the effects in relation to literacy and health literacy? You know, we think that people with lower levels of literacy may be disproportionately affected positively by multimedia, but we need evidence to back that up. What aspects of multimedia are used? We produced quite complex multimedia, and we want to know whether what aspects are used and what are the effective aspects, if only some of it is. And is this development time needed for all multimedia? So finally, I've got a number of people to thank. I won't go through these in great detail, but particularly thank the NIHR HS&DR program, which funded the study. And then we have thanks to people who worked on the study, the advisory group and the study steering group, the patient and public involvement group, thanks very much, and Morph, the company who worked with us to produce the multimedia. Thanks for your attention.